Okay, I'll just give a moment while everyone comes in. Okay, we've got a few more people coming into the webinar now. Okay. All right, I'll make a start. Good evening, everyone. I'd like to begin by acknowledging the traditional owners and custodians of the lands and waterways from which we are dialing in from today. We recognise their diversity, resilience and the ongoing place that Aboriginal and Torres Strait Islander people hold in our communities. We pay our respects to elders, both past and present, and commit to working together in a spirit of mutual understanding, respect and reconciliation. And I wish to extend that respect to any Aboriginal people connecting in today. My name is Katrina Martin and I'm the Program Lead for Workforce Development at Westvic PHN. I would like to welcome everyone to the second webinar of our Women's Health series, Sexual Health Update. Now, the majority of our webinar events are recorded and freely available on our PHN Learn YouTube channel, including the first webinar of this series, Pessary for Prolapse. We also have a practice communique that we send out to practices fortnightly with valuable information, including an internal and external calendar of events. You can also subscribe to the Westvic PHN fortnightly newsletter via our website. So you'll just see on your screen here some upcoming events. The first point there of the COVID-19 information session and panel discussion is on Tuesday night next week, where we have representatives from the public health unit, RACGP and Barwon Health to give everyone an update on infection prevention control throughout this COVID outbreak. We also have a number of project echoes. There's a youth mental health echo, COVID-19 every Thursday morning, family violence network starting very soon, and movement disorders network. Also, tomorrow night we have supporting young people and their families through grief and suicide, and we've got wound management and some mental health and AOD design workshops. So all of the registration details for these events that I've mentioned are available on the Westvic PHN Events and Education webpage, so you can register via there and find out a bit more information about each of those. If we go to the next slide, you'll see here that we've made note of the Westvic PHN health pathways that relate to this topic. For this evening's meeting, the participants will all be put on mute for the course of the meeting. If you have any questions, would you please type them in the questions box and we will ask your questions throughout the course of the meeting. So our speakers for this evening are General Practitioner Dr. Michael Roberts and Rochelle Hamilton, Sexual and Reproductive Health Clinical Nurse Consultant. So I will now hand over to Michael. Thanks.
Terrific, thank you very much. As mentioned, I'm a general practitioner. I work at Cardinia Health and at the Barwon Reproductive and Sexual Health, otherwise known as the BRASH Clinic. I thought I'd start with screening guidelines. They vary enormously depending on the demographic of the patient. There are guidelines that suggest that the under 25 should be screened annually. Many patients seek a STI screen when they start or are about to start a new relationship. Whilst the young are identified as a risk group to be regularly screened, we should not ignore the middle-aged patients repartnering after a long-term relationship. Sexual health services often suggest 3-monthly screening for men who have sex with men. Essentially, screening need to be tailored to the lifestyle and particular circumstances of the individual concerned. So the message is be opportunistic and make STI screening part of your general health care. You will all be familiar with the treatment of uncomplicated chlamydia of the urethra, throat or cervix, 1 week of doxycycline or a gram of azithromycin. It is important to be aware, however, that anal chlamydia requires 2 doses of azithromycin 1 week apart. The standard 1 week of doxycycline is still appropriate and is our preferred treatment. Symptomatic anal chlamydia requires 3 weeks of doxycycline. At the Brash Clinic, we also request LGV testing if the anal chlamydia is positive. Please ensure that contacts are notified, and if a patient is reluctant to do the notification themselves, the respective websites let them know, and the drama down under are simple ways to anonymously inform contacts that need to be screened and treated. Gonorrhea is usually managed well in general practice with ceftriaxone intramuscularly plus the oral azithromycin. I would encourage you to do a microculture and sensitivities for proven gonorrhea, as some strains are increasingly antibiotic resistant. Like chlamydia, there is a variation in the treatment in that pharyngeal gonorrhea requires ceftriaxone with 2 grams of azithromycin instead of the customary 1 gram. We advise a test of cure 2 weeks after treatment. Gonorrhea is notifiable, and once again, contacts need to be informed or traced and treated. Mycoplasma genitalium is a relatively newly identified STI. Some doctors are unfortunately ordering it as part of an asymptomatic STI screen. This is problematic because we will only treat Mycoplasma genitalia if the patient or the regular partner of the patient is symptomatic and the other pathogens have been excluded. Most Mycoplasma genitalia is now resistant to macrolides, such as azithromycin, and treatment will require a course of doxycycline for a week, followed by a week course of moxifloxacin, which is not on PBS and will cost in excess of $100. Specialist referral is worth considering in this setting. Hepatitis B, just a reminder that it is government funded for at-risk groups, such as men who have sex with men, so it can be offered for free. Also, when ordering hepatitis B serology, if you just ask for serology, you'll get surface antigen. So also ask for surface antibody so that vaccination can be offered if the patient has no detectable immunity. Core antibody will help distinguish between vaccine-induced immunity and past infection. With human papillomavirus, I would like to prompt doctors to consider Gardasil immunization for patients coming out of long-term relationships, particularly if they have had few lifetime sexual partners. I also wish to remind doctors that treating warts does not necessarily clear HPV carriage. It is done for cosmetic purposes, and as such, it is better to err on underdiagnosing rather than overdiagnosing possible HPV-related papules. Patients with HIV are sometimes thought to be immunocompromised, but this is not always the case. If patients are identified early, they can commence treatment before their immune system is damaged. Appropriate treatment, like with excellent diabetic control, should keep their immune system in good health. If, however, they are diagnosed with an AIDS-defining illness and a very low CD4, it is likely that their immune system is compromised, even if their CD4 count makes a reasonable recovery. PrEP is no longer on authority. It's a normal PBS prescription. Truvada brand is no longer available. PrEP is very protective from HIV at over 99%. It requires 3 monthly STI screening, and 6 monthly renal assessments. Bone metabolism can require monitoring with long-term PrEP or with other osteoporosis risk factors. There is also a new regime called PrEP on demand. It involves taking episodic PrEP medication rather than taking a daily tablet. It's quite protective, close to 90%, but not as good as the daily regime, and as such, it is not often recommended. PEP, or post-exposure prophylaxis, is available at no cost from the Alfred Hospital. For those unfamiliar with it, it is the commencement of antiretroviral therapy, or same as PrEP, within 72 hours of a possible HIV acquisition. The main indication is unprotected anal intercourse with a male of unknown HIV status. It is not indicated if that male is on PrEP or was HIV positive with an undetectable viral load. It's not as protective as PrEP, and it might be a good indicator to start PrEP. A 2-drug regime is usually adequate, the same as used for PrEP, unless the exposure risk was particularly high, i.e. group or chemsex, in which a 3-drug regime is recommended. PEP is available at Brash and Cardinia Health and through the emergency department at Geelong Hospital. From a practical point of view, it might be just as easy to write a script for PrEP to be used as PEP. Patients need immediate STI screening, and bloods should be repeated between 4 and 6 weeks. A reminder to consider HSV in your patients with recurrent thrush. Symptoms will overlap, and the presence of Candida does not exclude the possibility that the primary infection is that of herpes. Be aware that HSV can be a secondary opportunistic infection, especially in compromised skin, such as after waxing or laser hair removal. It is then referred to as eczema hepaticum. Lastly, I'd like to finish with a reminder to screen for syphilis. 20 years ago, we were getting about half a dozen cases of syphilis in Victoria a year. Last year, we had 1,400, and this was in spite of COVID. So syphilis numbers are rising dramatically. Of the 1,400 cases, 170 were women, and we've had 10 cases of congenital syphilis in Victoria since 2017. It's not difficult to treat. An injection of bicillin for primary, secondary, and early latent syphilis, and 3 doses 1 week apart for late latent infection. If you're unsure, please contact us at the Brash Clinic or me at Cardinia. And I'd like to remind people to be aware of the Jarisch-Herxheimer reaction. This is probably a blast from the past of student days, but it's not an uncommon reaction. 30% of patients being treated with primary or secondary syphilis will experience fever, headache, myalgia, and possibly rigors within 12 hours of the penicillin injection. It is transient and managed with fluids and simple analgesia. It's important that patients are warned that this may happen. Otherwise, they could end up seeking unnecessary medical advice. I was wondering if anyone had any questions before I handed over to Rochelle.
Hi, Michael. We haven't had any questions come through in the chat box as yet, or in the question box, I should say. So if any of our attendees have a question for Michael, please type them into the chat box now and I'll read them out as they come through. I might just pause for a moment to give people a chance to put something in.
I might have raced through that a little quickly.
No, that's okay. That's all right. We'll give people a moment to come up with anything. I'm just wondering, Rochelle, whether you might have any questions for Michael before we head over to yours, now that you've listened to Michael's presentation.
Hi, thank you. I think, thank you, Michael, and that was covered very nicely. Thank you. And I think it's always worthwhile, as you raised on that HPV slide, about overdiagnosing papules, because just to remind people, we have had people sent in for wart treatment and certainly hasn't been. And the same issue with that you raised with thrush and HSV, if you might like to touch maybe on bacterial vaginosis, is a very similar issue that's raised.
The as co-infections.
Yeah.
Yes, yes. No, a good point. Bacterial vaginosis being our commonest recurrent discharge, it would be very important to consider co-infections such as HSV. That's a good point, Rochelle.
Okay, we have had another question come through in the chat here. Do we treat pregnant women with hepatitis C or after pregnancy?
Look, I probably would take advice on that. Hepatitis C in Australia is not often an STI. It would always have been preferable to treat someone before they fell pregnant for their hepatitis C. I would need to have a look at the toxicity of the medications that are used for hepatitis C, and then it would be a risk-benefit analysis. My gut feeling would be that unless someone was particularly unwell, they probably would wait until after they've completed their pregnancy before commencing hepatitis C treatment. But I would need to maybe have a look at the safety of the medications being put forward. But I suspect that they will probably be regarded as not being particularly safe.
Rochelle, did you have any other questions for Michael before we head over to yours? We can also, if anyone thinks of questions for Michael while Rochelle's speaking, you can still put those in the chat and just let me know it's a question for Michael. We can address those at the end.
Yeah, absolutely. I'm happy for people to still ask Michael questions throughout anyway. Yeah.
Yep, sure. Okay, I'll hand over to you, Rochelle.
Thank you. Okay. So that's a nice introduction now to, now I've lost my screen somehow.
We can see your presentation, Rochelle.
Trouble is I can't.
Yeah.
All I can see is Michael and myself.
Okay, I wonder if you hover down at the bottom of your screen where the go-to icon is. Can you click on that?
So now I can see my screen. Is that fine? Can you still see?
Yep, that's fine.
Okay,
yes,
awesome.
Perfect. Thank you.
So I'm going to lead on to mainly the syphilis in women and talking about pregnancy, mainly because, as Michael had stated on those last couple of slides, our concern that has been raised through the DHHS in relation to our increasing pregnant cohort with syphilis, and specifically targeting that since 2017 from a national perspective. And as Michael already said, the cases had increased over the last, since 2017, 10 congenital cases in Australia. the issue around that was the congenital transmissions at the time were mainly picked up in the 3rd trimester. And as we know, we routinely have been doing 1st trimester. However, the majority of those 10 cases, the women were negative in that 1st trimester. And that's how the new guideline came about to test around 28 to 32 weeks. So the referrals for that, as Michael also stated, even though there were 1,400 odd cases of syphilis across the board, the COVID situation has decreased not only the syphilis cases, but in general, the STI screening for men and women. So that has been raised again through the department about the need to remember antenatal screens and inclusive of syphilis and looking at those guidelines. The transmission, a higher risk of women for transmission across the placenta to the fetus, it peaks at 14 weeks of gestation. The other issue to be reminded about with that is shifting from primary care referral to pregnancy care for antenatal ongoing management. Please remember to do at that time all antenatal screens, but importantly to check those results, because by the time a lot of the women get into pregnancy care clinics, sometimes they're well past 14 weeks for that first antenatal visit. And it does take sometimes a couple of weeks, or sadly some have been missed, of picking up with the syphilis result as being a positive, because they had been assumed that the GPs had done that follow-up, and the GPs had assumed that the pregnancy care clinic had a timely follow-up. So that's been another thing that's been raised through the department about that concern. Why won't my screen move? There we go. So what was managed through the department, what came about from all of this discussion from last year, were all these brochures and posters that were put out and made through the department, not just across to general practitioners, but all allied health carers and anybody that was basically coming into women, like physios, osteos, etc. as well. So this test, treat, educate and champion change posters were put out. Notifications were also released to allied health practices, and mainly targeting women of fertile age, 15 to 49. And I know many people will be going 49 years. Why? But due to planned or unplanned pregnancies, it was targeted because of the fertile years. This pamphlet explained to women about the transmission of the syphilis. It explained how to identify any symptoms. Importantly, it raised issues around discussion for their health practitioner to look at, talking about risk of congenital syphilis and partner notification and treatment. And it also highlighted to remind people to do the notification to the Department of Health. With the syphilis serology, when we're looking at that just through the University Hospital Geelong, Barwon Health, the syphilis screenings were taken from 1st of January 2019 to middle of April this year. Just over 5,500 screens were done just in those services, obviously through antenatal care and the sexual health clinic. When we're looking at what we're trying to prevent, $15.65 for Medicare test is not so big. These slides here are directly from the department's official website, and it highlights what we're talking about with looking at our fertile age group, 15 to 49 years, targeting women specifically. Note the peak of the syphilis is really between 25 and 39 years. That's when there was the peaking. And the mean age for women was the 30-odd year age mark and men 35. When we're looking at first-time pregnancies for women, since 2019, it has raised from 29.2 years to around 32-year age group now. And when you still look at that transmission risk and the group of infectious syphilis, it's significant still in that 35 to 39 year age group. Again, when we're looking at this, the increasing proportion of cases in women when they were pregnant at the time, you look at that has risen from 2017 up to 2019. And last year, even though it was a little bit of a decrease, the department were worried that due to COVID, the screens just weren't undertaken as regular as they should have been. So it's significant risk factor in the orange bits on those bar graph there when you're looking at positive cases in women that were tested at the time of their pregnancy. Again, on this chart here, when we're looking at the rate of infectious syphilis in women, it has basically doubled since 2016 to 2020, going from 94 cases in that age group up to 177. What's concerning in this slide here is the transmission risk. And when you look at these bars, the majority of these women were being experienced, who experienced acquisition of syphilis were through regular partners. This is the likely source of transmission. One thing to remember with this slide here about regular partner, when you're looking at risk and thinking, is that woman high risk? What actually defines high risk? She might think she's in a monogamous heterosexual relationship, and that's been the whole push, I suppose, for screening again in that 28 to 32 week mark. If the woman thinks she might be in that low risk and you go on that, often these things are missed as well, especially when you consider the transmission risk has been with a regular partner for a lot of the cases here. So the first trimester screening routine, 28 to 32 week routine, if there's been any concern, any symptoms, any change of partner in that time frame, or any previous positive syphilis result, it is advised also to do it again at delivery. So those are in those RANZCOG guidelines. When we're looking at infectious syphilis in women, again, detected mainly through antenatal screening. So this is what we have to keep a focus on. The first trimester, 28 to 32, and at delivery if required from the comment I just made. When we're looking at that, not many had syphilis symptoms. When you see the green bar on there, not many had symptoms. They were mainly asymptomatic and antenatally detected. So from that, I will just go on to the process of referral to the Choices Clinic. This seems a bit odd going from syphilis in pregnancy to referral for termination. But it's been raised constantly through our service, through the Choices Clinic, about how the referrals are happening, forgetting to follow the pathway, the clinical pathway guideline through the PHN site, and what's expected on that journey for the woman. I have been working with the Choices Clinic for about 24 years now at the Geelong Hospital. We do not do medical termination at the hospital anymore at this point. We are looking at trying to bring it back into the sexual health clinic. However, that's just not possible at the moment. So the only referral for a surgical termination is via the Choices Clinic. The referral ideally should be under 12-week gestation. We will do to 14 weeks, and if the woman is like 12, 13, 14 weeks when you're referring her, please still just make the phone call. It's not routine to do it above 14 weeks, but we do have a couple of doctors that will at the moment, but it depends on the rotation that the doctor's on for the surgery to happen. So up to 14 weeks we'll accept. Referral goes to social work admin. There's their phone number there. If you have any questions, you can ring and speak to very helpful administration ladies. If they have any concerns or queries, they either ring myself or then we ring the consultant directly associated with the termination service. With the women, some women are still coming through without full pathology, and that is a delay for them, and it is a delay for our rotation to theatre. Thankfully, we have weekly theatre now for surgical termination when we didn't last year. Now, the referral process is fairly straightforward. We do like to consider that baseline sexual health screens have been done, including gonorrhea. So gonorrhea and chlamydia as a baseline. Urine test is fine. However, if you've kindly had some sort of discussion with the woman about contraception and she's sort of leaning towards an intrauterine device of some sort, please do high vaginal swabs instead of just a urine, and add to that a bacterial vaginosis screen and a firm screen. We prefer to treat symptomatic and asymptomatic BV before we put in an IUD at the time of the surgical termination. We do have a couple of practitioners or a couple of consultants who preferably do not put an IUD in at the time of the termination if they have a positive untreated BV. And if I'm doing the swabs on a Friday and they can go to theatre on the Tuesday, we don't have time to get a result back and start treatment, even if they can just start treatment. Sometimes we'll do prophylactic if it seems like it's symptomatic, but otherwise it can be a delay for them. Prior to having that, please add into that, and I know this sounds straightforward, but it does get forgotten on some of those referrals. I need a blood group. I don't need a beta HCG on a surgical termination, but I do need a blood group. Sometimes I've got absolutely everything on that screening coming in and no blood group, and we haven't got a history of a blood group through ACL or the hospital. So please add a blood group for me. The request of screening is this, as I've just said. If you can, and if the woman can get in a timely fashion for a gestational ultrasound, if they're under 6 weeks and being referred in, there's no point in doing an early gestational ultrasound for us at that time. We prefer one after 6 weeks. We're not going to do a surgical termination under 6 weeks anyway. So some of the women have had ultrasounds at 4 weeks. They come in, we can't see anything to speak of on that ultrasound result, and they need to go for another one if it can't be done at the time. If they come in about 8 weeks, sometimes the docs will do it in outpatients there, but sometimes we just can't. So just remember about the worthiness of the ultrasound at that time, and the STI screens are really important. It would be helpful and good for time management for our point of view in the clinic about contraception. I spend a lot of time with the ladies personally talking to them about contraception at the time of the termination, but if it could be sort of hinted at to them and help them think about some options, and then we can go from there and elaborate on that in the clinic. Referral for a genetic issue like trisomy or Edwards, something like that, or a threatened miscarriage. The Choices Clinic is not the place to make the referral. That goes through EPAS. You need to refer into EPAS. You can make a phone call to the registrar who's on for EPAS during the week, or you can make a phone call to the ONG consultant who's on call. But those referrals don't come through Choices. Sometimes some of the women will end up on our Choices termination theatre list, but that's a completely different thing that occurs. But the referral really does need to go through the EPAS clinic. Just remembering the pathways that were shown at the beginning. If you go onto your clinical pathways through PHN, you just click onto these and you'll find the clinical pathway referral process for the Choices Clinic and for anything associated of any of these. So that would be helpful and help with timing of our referrals as well. Okay, I have finished.
Thanks, Rochelle. Michael's given you all that stuff as well. Now, we do have a couple of questions coming through the chat. I'd just like to let everyone that's listening know to pop your questions in now, and we'll move into that Q&A time. We've got plenty of time. So, firstly, we have a question asking, where do you refer for medical termination of pregnancy, and do you do these, Mike?
Yes, I do medical terminations, and we have a number of doctors at Cardinia Health that provide that service. There is a list of local content providers. I know that there's some in the in North Geelong and down the coast. And Rochelle might be able to help me with this. There's I think it's the Jean Hales group will actually have a list of providers. Mari Stopes, thank you very much. Mari Stopes have a list of providers that that are currently registered to prescribe the medications. So I know that at Cardinia Health we actually have a little list of alternative providers that the receptionists are able to pass on to patients if we're unable to attend to inquiries in a timely manner. But I can't remember the names of the clinics offhand.
I can answer some of that. I can't see anything on my screen anymore.
We can see you.
I can,
we can see you.
Okay, that's a bit sad. So our receptionists, our admin ladies at Social Work Department on the 42150777 number, we do have a list of all the providers in our region. And if the women, sometimes if they're super not sure, or they make their own initial referral just to find out about things, sometimes the admin ladies will get the ladies to talk to myself, and I will tell them the pros and cons of both, and they make up their mind. But we do have a list of the providers within our region, and we do pass that on to the women to make their own referral to the primary care physicians that do provide it. There are a number at Surf Coast that do it. There's one or two down at Anglesea. There's a couple out at Lara, out at Yuyangs, etc. And there's a couple at Geelong City itself. So we do have a list, but you can access that through Mari Stopes' website.
Thanks, Rochelle. And we do have a couple of comments here just saying Anglesea Medical.
Yeah.
Okay, another question, and it is our last question that's coming through the chat. So once again, just pop your questions in there. We've got plenty of time for them. So do patients have to have a scan prior to surgical termination of pregnancy?
In the ideal world, we do. Just to confirm where the pregnancy is situated, sometimes the docs will have a query, especially if it's super early, that they come through to us, and then there's no point in doing a bedside one either. And we do sometimes ask the ladies to go and get one and come back in a fortnight. Some of the doctors will do a bedside one on the Friday morning in clinic, and some of them prefer not to. And it is about the timing of going to theatre. And like I said, now it's not so much of an issue that putting them off 1 or 2 weeks when we can provide surgery weekly now at the hospital. But in the ideal world, after 6 weeks, it would be nice. But I know some of the ladies have made comment that they've chosen not to go and get it because of the cost, or because of maybe this is their second or subsequent termination, and they've had really bad experiences at the service that they'd been to before for an ultrasound, and they don't want to face that again. So that's a bit of a shame, but that does happen.
If I could make a mention that, I mean, I obviously am not involved in surgical terminations, but for medical terminations, the purpose of the ultrasound is merely to confirm that it's an intrauterine gestation, and that the pregnancy is under 9 weeks. We do have an ultrasound unit at Cardinia, but it's a bit unreliable, and it won't as reliably pick up early pregnancies. So an external ultrasound is preferred. Some patients get referred with a full antenatal workup, which is not needed for a medical termination. We're just interested in a beta HCG and a recent chlamydia and a blood group. The beta HCG needs to be within 3 days of seeing us. Sometimes we do require a repeat of the beta HCG because it's been done a week or 2 weeks before the patient is seen by us. The purpose of the beta HCG is not to confirm pregnancy, it's to provide a baseline by which we can compare with when we repeat the beta HCG 10 days after the miscarriage, just to confirm that it's been a successful procedure. That's the reason why we need a recent beta HCG rather than a historical one. And when ordering an ultrasound for a lady who's having a termination, it's quite understandable that many ultrasound providers, if they are not given a heads up, will be effusive about the early pregnancy, which is not quite the appropriate emotion if a lady is going through the trauma of being prepared for a termination. So when I'm ordering an ultrasound for a future termination, I do actually write on the notes that we're only interested in gestational site and dates, and in brackets, for TOP, just to give the providers an indication that this is not a pregnancy to celebrate with the patient. And I've found that that most of the patients report back that their experience at the ultrasound was a good one and a professional one rather than one that was a bit traumatic. It is expensive though.
Thanks for that, Michael. We do have another question that's come through in the chat. Can you do MTOP for blighted ovum?
Yes, absolutely. We can do it for an incomplete miscarriage. So sometimes a patient will be referred for a termination, and they will not have a successful pregnancy. They'll either be miscarrying by the time they're seeing us, but using the mifepristone and the mesoprostol therapy that's used in for a medical termination as part of MS2 step is a very successful way of completing either a miscarriage through blighted ovum or through incomplete miscarriage. It is definitely an option. The pregnancy doesn't need to be a viable pregnancy for this process to be undertaken, with the exception of a tubal pregnancy, obviously.
And just to remind people, I understand that Alex Bonner's going to be doing a presentation for PHN on medical terminations. I'm not sure when, Katrina, do you know off the top of your head? But she's one of the providers at the hospital for the surgical termination, one of the ONG consultants. And the reason that has come about is just about some of those questions that have been asked and what Michael's just said, but also to try and encourage some more primary care physicians to participate in doing MTOPs, and understanding that the ONG team at the hospital are very much supportive of if there's a hiccup along the way, if there's questions like you're asking now, that they're happy to answer and support, or if a woman has an incomplete termination and she's got retained products, about the pathway to the hospital and the support for the woman and the support for the clinician as well. I understand that she will be doing a presentation in the very near future for this.
Yes, so that's October.
Sorry, I didn't hear that.
26th of October.
Oh, okay, there you go.
For that session, yeah. So we haven't opened registration for that one yet. It's all further down the track, but in about a fortnight we'll open up registration. So people just keep an eye on our education events webpage that Jade put the link into the chat earlier. It'll come up on there in a couple of weeks.
That's good.
Now, we did have another question come up in the chat, and I'm going to, please forgive me if I get this medication name wrong. Do you still use MIFIP? I'm going to spell it. MIFIPRISTONE for that? Or just, yes, or just Mr.
Misoprostol.
There you go.
What's the actual question?
That would have been related to something you were speaking about 3 minutes ago.
Yes. So the MS2 step, which is used for medical terminations, has an initial tablet of mifepristone and followed up by 4 tablets of buccal mesoprostol. Have I got that right, Rochelle?
Yes, buccal mesoprostol.
The person who's asked this question has just popped another comment in to clarify. For blighted ovum, you don't need MS2 step, do you?
No, you could probably just go to.
Depends.
You probably in both instances could probably just go straight to the mesoprostol, but yes, there is that point. The first medication tends to be a hormone disruptor, whereas the second medication tends to be an inducer of uterine emptying. So that's the actual most important one in an incomplete or blighted ovum. So we could just use the second medication, the mesoprostol.
So yes, the person that's asked that question has just agreed, yes, just the mesoprostol.
Ah, excellent.
That makes sense to them, yeah.
It's good to be on a Unity ticket.
Okay, now we don't have any other questions coming through. We still have 10 minutes. I'm happy for it to finish up early, unless there was anything else, Michael and Rochelle, that you wanted to go into a bit more detail on, or anything you haven't covered that you'd like to bring up.
I'm hoping that that GPs will become more comfortable with prescribing PrEP. It is so easy to prescribe. It seems unnecessary for patients to come to me or to the Brash Clinic just to get their PrEP renewed. I mean, I concede that syphilis is a bit complicated, but PrEP is not. It is, it's a little bit like the hepatitis C treatment. It can be a little bit, people can be a bit tentative about what's involved in the treatment, but once you've done it once, it is a very simple process. And generally the consultations are quick and uncomplicated, and that can even be done over the phone. I will often, with patients that are asymptomatic, will mail out a request form for their next test in 3 months' time, and send a script over the phone. You know, as an electronic script. And it just means that people get to keep their relationship with their GP rather than have it diluted by going off to see other doctors.
And can I just add to the PrEP issue? It's not just men who have sex with men. So if you look in the ASHM guidelines now, they've finally put in women as well. And because, you know,
Are you saying that women have sex with men?
Oh, shame. But also women participate in anal receptive sex. If you ask, you'll get told, but you have to ask. But also the risk of women and men and so many different types of sexual identities now that you know, it does get a little bit complicated, and women don't always know who they're having sex with, as in, is this a heterosexual relationship? So be mindful about asking about risk, and sometimes it might be something that might need to be suggested to some cohorts of women as well. And it's in the ASHM guidelines now to just remember about women.
Okay, we don't have any other questions coming through in the chat, so I think we'll all for an extra little bit of time in our evening and finish a little bit early. So thank you very much to our presenters for this evening, Dr. Michael Roberts and Rochelle Hamilton. We're very fortunate to have such expertise available to us. And thanks to all of our attendees. If you could take the time to complete the evaluation, which will pop up as we end the session. So thanks a lot, and hopefully we'll see you all on the 26th of October for the next in our Women's Health series, Medical Termination of Pregnancy. Thanks everyone. Good night.
Thank you.
Thank you.